Finally, regarding our cancer homeostasis modules of learning, we're going to cover chemotherapy, treatment modalities, specifically chemotherapy. First of all, what is chemotherapy? Chemotherapy is an adjuvant treatment modality for cancer that has spread beyond the localized area and out into the system. And what that means is the primary treatment modality for cancer is surgical removal of the tumor. That is always what they're going to do first, if it's at all possible. In an attempt to improve the survival rate or at least increase the survival time, adjuvant treatment modalities are used. One is chemotherapy, and another adjuvant treatment modality is radiation. We are not going to discuss radiation, but we will limit our talk to chemotherapy, and just know that the use of it is to help potentially, hopefully, cure the disease and at least increase the survival time. The chemotherapy has some selectivity for killing the cancer cells over normal cells. It's definitely a risk versus benefit type decision that patients would have to make. Chemotherapies are given systemically via various routes, depending on what part of the country you're from. And they exert their cell damaging effects against both healthy and cancer cells. And cell damaging is called cytotoxic, toxic to the cells. And fortunately, it also hits those healthy cells. And that's where the risk benefit, again, comes into play. The chemotherapy affects cells that divide rapidly, such as the cancer cells, but also the cells of the skin, hair, intestinal tissues, spermatocytes, and blood-forming cells. Those are also some of the most rapidly dividing cells in our bodies that are normal. So that's why those are hit the hardest. Because of this knowledge, you should now be able to recognize the patient's resultant symptomatology that may occur in each of the areas of the skin, the hair, intestines, the spermatocytes, the ability to create sperm and have babies or make babies. Men don't have them, they make them. And of course blood-forming cells such as red blood cells. How is the chemo drug chosen? The selection of which drug to use is based on, this is a fancy way of saying basically the type of cancer cell, but it's cellular kinetic concepts. Kinetic means movement, activity concepts that include the cell cycle, growth factors, and tumor burden. In other words, selection is based on the sensitivity of the cancer cells to the drug and the stage or extent of the disease. There is a slow trend towards doing genetic profiling of the patient to determine the likelihood of experiencing dangerous side effects. If you remember in the OB section, I talked about genetic, I can't think of the word now, genomics, Genomics, of the genomics and how valuable that can be in the future in helping us understand what's the best treatment for our own personal individualized body. So there's a slow trend towards doing that and using that modality. And also checking the genetic profile of the tumor itself can determine its sensitivity to various chemotherapy agents. If we knew exactly which one would work the best, the guessing game is pretty much gone and we know how to best treat it. And this is fortunately a growing trend in chemo selection. Different chemo drugs will have varying occurrence times of when immunosuppression is at its lowest level. And that's called the nadir. Remember in electronic fetal monitoring, what nadir meant? It means the same thing. It's the lowest level. The nadir in fetal monitoring referred to the nadir of a deceleration. How low did it go? In this case, we're talking about the nadir of immunosuppression, which is the biggest risk time for infections, of course. The goal is to avoid combination chemotherapies that have similar nadir times. We don't want them to be totally suppressed. Well, they're going to get totally suppressed, but we'll try to minimize the risk of side effects, specifically severe infections, because of that. There are at least five, and these are the only ones specifically mentioned, so they're all we're going to talk about, chemo drug categories. The alkylating agents, these make the DNA strands bind tightly together, and this prevents proper DNA and RNA synthesis, which inhibits cell division. Kind of think of it as, you know, they're imprisoned, they're bound up so tight they can't divide out. They're like prisoners of the agent, and so that's a good way to deal with it. Antimetabolites are similar to normal metabolites, which are needed for vital cell processes. So in order for our cells to do their job, we need what are called metabolites to function. And these antimetabolites are basically counterfeit metabolites. They fool the cancer cells into using the antimetabolites in cellular reactions instead of the healthy metabolites. This replacement of regular metabolites with antimetabolites impairs cell division because the antimetabolites cannot function as proper metabolites. So think of Rhogam, how we fool the body into thinking it's doing something that it isn't really doing, because over time that will wear off. So that's kind of what this is like. That's what it reminded me of when I was reading about it anyway. Everything to me goes back to OB. All right, antimitotic agents. You know what mitosis is, right? Mitosis is the division of the cells, okay, so that they can become 2 or 4 or 8. Well, antimitotic prevents that division. It interferes with the formation and actions of microtubules so that the cells cannot complete mitosis during cell division. And therefore, those cancer cells either don't divide at all or they only divide one time. Minimizes the growth. Antitumor antibiotics damage the cell's DNA and interrupt DNA or RNA synthesis as well. I don't have an analogy for you on that one. Topoisomerase, I'm saying that wrong. Okay, I gotta look at it. Topoisomerase inhibitors, I'm going with that. They disrupt an enzyme that is essential for DNA synthesis and cell division. So the enzyme is what's being attacked here. When these enzymes are disrupted, proper DNA maintenance is prevented, and that leads to breakage and death of the DNA, and therefore breakage and death of the cancer cell. What is the method of treatment of the using of the chemo drugs? They're given on a regular basis, and they are timed to maximize cancer cell kill and minimize damage to normal cells. The intent is to allow normal cells time to recover from any injury, but not allow adequate time for cancer cells to recover. Sounds very tricky to me. They're usually scheduled every 3 to 4 weeks for a specified number of times to complete a full treatment. Most are given the IV route, but other routes are possible. The intrathecal is given right into the spinal canal. Those would be, of course, your bone spine cancers. Intraventricular would be given into the ventricles of the brain. Intraperitoneal goes within the abdominal cavity, and specifically to that would be your ovarian cancer. Intravesicular are bladder cancers, and intraarterial may be used to deliver higher doses locally, which, for example, in liver tumors, little anti-cancer beads are put in the arterial area of the liver, and they then become trapped within the really small arteries feeding the tumor, and they just hang out there doing their anti-cancer action. Special considerations with chemo drugs, very important. These are really important treatment precautions. Administration of chemo drugs requires special education and handling. Most chemo drugs are absorbed through the skin and mucous membranes, even the oral ones, so healthcare workers are at risk for absorbing them. We have to use extreme caution and wear our protective gear, including either double gloves or special chemo gloves to protect our hands. A serious complication of IV infusion is called extravasation. Oh, look at this picture. You can see what happened. She had an IV in her hand and the chemo drug got into the skin, out of the vein and into the skin. Kind of makes you wonder how the veins survive it, now that I think about it. But yeah, it goes under the skin and just eats away at the skin. These drugs damage tissue on direct contact. And the most important nursing intervention is prevention. We have to carefully monitor the infusion site, even when there's an implanted port. Patients that have frequent chemotherapy treatments will often elect to have a port so that they don't have to get stuck every time they go in for chemo. And those ports are less likely to have extravasation occur, but it can still happen, so we have to really watch it carefully. The damage will be minimal if just like a half a milliliter of fluid gets out, but you get much more than that, and that's not much, okay? Half a milliliter, half a cc. But after, over that amount, it can get real severe. Oral chemo drugs, there are about 24 available. They are more convenient, but just think about it. It's a pill. If I don't take it today, no big deal, right? That's kind of the tendency that some people may have. So adherence to a schedule is more of a problem. Patients think that skipping a dose or reducing the dosage has only a minor impact, but that is not true. Also, patients and non-oncology nurses can perceive oral agents to be less toxic than IV chemo. And again, this is not true. The oral chemo drugs must not be crushed, split, broken, or chewed. I can't even imagine. They're going to do that to your hand. Who would chew it? I don't know. I don't know why it's in the stomach and doesn't do it. I don't know. See, I'm digressing. Oral chemo drugs are biohazardous and must be discarded in accordance with agency policy. Side effects, of course, chemo side effects. Many of you, most of you, all of you have probably heard of many of these because it's what patients are going to most likely complain about, and I don't blame them. The side effects can be temporary or permanent. Damage can occur to normal tissues because all cells are affected. Hemorrhagic cystitis, cardiac muscle damage, and loss of bone density may occur. Some cancer therapies allow for a pre-medication with cytoprotectants or chemoprotectants to decrease this impact. So, of course, think of the word protectant, cell protectant or chemoprotectant to decrease the risk. Chemo side effects are a result of suppressive effects on bone marrow, blood-forming cells. Therefore, the risks are due to anemia, neutropenia, and thrombocytopenia. We'll talk a little bit more about those in detail in a future slide here, but right now the common distressing side effects, these are not going to kill anybody, they're not going to cause harmful long term, but they are very annoying. This is your nausea and vomiting. We've all heard of that, I'm sure. Alopecia, losing the hair. Mucositis, damage to the oral mucous membranes in the mouth. Skin changes can happen. Anxiety, sleep disturbance, altered bowel elimination. They can get very constipated. And changes in cognitive function. There's a term called chemo brain, and it is not just, it's a real thing. It's priority nursing care issues for our patients with chemotherapy are to protect them from the life-threatening side effects and to help them manage the associated distressing symptoms. We'll talk about the resultant concerns from bone marrow suppression, which is also called myelosuppression. You may see that term somewhere, so know that marrow suppression is bone marrow suppression. Neutropenia is the biggest concern. That's the biggie. If somebody were to say, what's the biggest concern with chemotherapy? You're going to say neutropenia, okay? Because the wiping out of the bone marrow wipes out the white blood cells, the red blood cells, and the platelets, okay? So having neutropenia will greatly increase their risk for infection. And this is the biggest concern and can lead to an extreme risk of sepsis itself. This is the major dose-limiting side effect of cancer chemotherapy, and it can lead to death during treatment. If neutropenia did not happen, they'd probably zap us with even stronger chemo, but because of the risk, they don't. The severity of the risk is directly related to drug dosage. The most common infections are fungal, bacterial, and viral breakthrough. And when I was reading this and creating this slide, I'm thinking, what else is there? I don't know of any others. Maybe I'm missing something, but pretty much anything, okay? Most infections result from an overgrowth of the patient's own normal flora and an entrance of these organisms into the patient's bloodstream. So there you get your sepsis, okay? Infection risk can be managed by biological response modifiers, BRMs, and growth factors to stimulate bone marrow production of immune system cells. So they do attempt to try to increase immune cell production, but it's still not going to be completely successful. We need to teach our patients to report any areas of open skin, such as pimples, sores, rashes. Those could be what are we called portals of entry of bacteria. We also need to teach them to report any coughing, burning on urination, pain around the venous access site, or any new drainage from any body area. Those are all potential symptoms of potential infection, and we need to catch them early. Let's teach them to have good mouth care. We talk about this, I think, a little bit more, but right now the mouth care would be use a soft toothbrush, do gentle flossing, but mouth care is very important. And washing of the axillary and perianal regions at least every 24 hours, again, to minimize the bacteria in those high-risk areas. Due to reduced neutrophils, the patients may not exhibit normal signs of infection. They may not get the high fever or purulent discharge or drainage, even when severe infection is present. So that's why we need to teach them to report these symptoms that can indicate infection. The next consequence of myelosuppression is anemia. And of course, they're going to be very fatigued and have hypoxia symptoms. You're going to notice a decrease in capillary refill and increase in capillary refill time, etc. Sometimes patients need blood transfusions to get them over the worst of anemia. There are what is called erythropoiesis-stimulating agents, or ESAs, which are used to stimulate red blood cell production. This can reduce the need for transfusions, but it increases the risk for hypertension, blood clots, strokes, and heart attacks. It's like, pick one. Which one do you want to worry about? Thrombocytopenia is very similar to the anemia. Of course, it increases the risk of excessive bleeding. Those platelets can get very, very low. They also may need blood transfusions, and growth factors can stimulate red blood cell and platelet production, and that is often used in these patients. One example is oprelvacin or Numega, and these increase platelet production, but causes fluid retention, increases the risk for heart failure, pulmonary edema. So again, pick your poison. That's pretty much what that seems to mean. Managing the common non-life-threatening side effects, very important. We are worried about the internal body, but the patients are worried about how they feel today. We have to understand that and help them through that. CINV stands for chemotherapy-induced nausea, vomiting. So that's what the CINV means. It's interesting, the anticipatory type, that can happen before the treatment even begins. They so fear it that they create it. So that can happen. We treat it as a true nausea and vomiting. We don't poo-poo it, but understand that anxiety can create that. It may be acute, and in fact, the acute nausea and vomiting is the most common type, and that happens within the first 24 hours after treatment. The delayed nausea and vomiting may happen after the first 24 hours. It kicks in late. There may be breakthrough nausea and vomiting, which can occur intermittently during the treatment, and of course, any combination of all of those. Chemo-induced nausea vomiting can now be well controlled with appropriate antiemetic treatment, especially with serotonin antagonist drugs and standardized protocols. They've made a lot of progress in that area, thank goodness, because it was needed. The patient's response to the antiemetic treatment is variable, and drug combination for each is individualized for best effect. It works best if the medication is started before the nausea and vomiting are out of control. The mucositis, which are sores in the mucous membranes, they often develop in the entire GI tract, but especially in the mouth. It starts in response to the cytotoxic treatment. Pain will result in the mouth, so they can't eat, interferes with quality of life. It's got to be miserable. I can't imagine not eating. I just don't even want to imagine not eating. Frequent mouth assessment and oral hygiene are key. It's important to have the patient also, when they're home, to be evaluating their mouth for any lesions or sores, and then keeping their mouth clean. And this is where I was mentioned earlier, the soft bristle toothbrush, gentle flossing daily, clean the toothbrush weekly, and then pain relief is a swish and spit compounds, and these contain a local anesthetic. We have to teach the patient not to swallow it. Okay, swish and spit, not swish and swallow. Alopecia, hair loss. That's probably the one I would think most women worry about the most, I'm guessing. I don't know. I did not do a research study. I'm just guessing. But our hair is so important to us. And alopecia may involve the whole body, or it may just be a thinning of scalp hair. No one really knows how they're going to react to it. Some women don't lose hair at all. Men, same. Some men do not lose hair at all. But it is definitely a risk of occurring. And we can reassure our patients that hair loss is temporary. It will grow back. Regrowth usually begins about a month after the therapy is completed. And this is kind of fascinating to me. The hair, when it comes back, may be and probably will be much different. The texture, the color, the thickness. I was at a volleyball game last Saturday. Yes, my granddaughter's volleyball game. And the lady I met, she had gone through breast cancer years ago, and she showed me a before picture. Her hair was black, long to her waist, and totally straight. After her therapy, her hair, when I met her last Saturday, was short. Well, she could have grown it out, but it was short and very curly. It was so cute. Totally different than what she'd had before treatment. So my sister went through therapy. She was actually kind of interested to see what her hair would do. It didn't change. She had the same thin hair. So everybody's different with that. If the patient ends up with a hairless scalp, whether male or female, we need to teach them how to prevent sunburn of that scalp, because it's not something we're used to worrying about. And wear a head covering to protect for sunburn, and also wear a head covering to protect from the extreme cold weather to prevent hypothermia. Changes in cognitive function are real. Okay, some patients experience a reduced ability to concentrate, they have memory loss, and they have difficulty learning new information. That's why it's so important that they always have someone they can trust to be with them on any physician visits, follow-up visits, so that this person will have the ability to write down the information for the patient. So the patient is getting correct information and doesn't have to worry about not remembering it. This change may continue for months to years after the treatment is completed. There is, again, that chemo brain. It is reported most often in women who are being treated for breast cancer. In comparisons of brain structure and cognitive function before, during, and after high-dose chemo show anatomic changes in the white and gray brain matter. So it's fact. It's a objectively found fact, and this usually resolves by 3 years. Chemo-induced peripheral neuropathy, CIPN. This is a loss of sensory or motor function of the peripheral nerves associated with exposure to certain anti-cancer drugs. Personally, this is the one that's most concerning to me. I would be most concerned about this result. Some patients undergoing chemo with nerve-damaging drugs, those will be the antimitotics and the platinum-based drugs, have a rapid onset of severe CIPN. The degree of CIPN is related to the dosage of the drugs, and there are no known interventions to prevent it. The most common problems that result from this, if you lose sensation in your hands and your feet, just realize how much that would impact your daily living. You can't feel your feet. So at the bottom there, you're going to see that falls are more likely because they cannot feel changes in the terrain that they're walking on. They're going to trip more easily. And also because of orthostatic hypotension, which is a common problem in the CIPN patients. Men can experience erectile dysfunction, which of course would be quite disconcerting for men. There is neuropathic pain that just happens that's due to the neuropathic areas. I can't even imagine. Loss of taste discrimination. Again, I can't imagine that one. And severe constipation is another potential problem, and that's because of the neuropathy in the GI tract. Nursing implications for patients on chemotherapy. You tell me. We've gone through several different angles. We're going to talk about this more in class. But think of all the various likely and potential fallouts, I call them, due to chemotherapy, and how can you as a nurse help the patient either prevent or manage the fallout. So that's one of the things we'll talk about in class. I hope you enjoyed the chemotherapy. Short and sweet.